CMS TAC Group with Element Rescue, Renegade Medics. We're back. Long break. Got jacked up with COVID and taking a hiatus. We're trying the Zoom thing here and see how it works. So how's everybody doing? Decent? I think everybody's alive. Justin, you had COVID, right?
Yeah. 3 weeks of fun. Nice.
All right.
I'm apparently impervious to COVID. I've been all up in COVID all day, every day, but
as have I.
So,
yep.
Yeah, I tested negative for it, but definitely tested positive for an incredible GI issue that landed me in the hospital. That was incredible. Rural hospitals in Wyoming, phenomenal.
Excellent.
Lovely.
Well,
JJ was in charge. He was going to potentially have to run an evac on me, man, like covert CASA 220 and freaking popping smoke and stuff, but it didn't come to that.
Yeah, I may or may not have legitimately acquired a CASA. You can ask Julie, and was ready to fly out of South Carolina. So, that's love. It's a beer thing. I can't say no.
Stop eating those buffalo testicles when you're out there, man. That's why.
Yeah. The KC.
So we're gonna do
They're like hard oysters.
IFAC. Blow everybody's mind.
We got lazy, right? And that's my take. Is we jumped the curb big time on just even getting the idea that everybody needed an IFAC and that people should actually know how to use it. And then that was it. And then nobody really, especially in training, started to enforce the usage of IFAC, right? So you carry it, but how many times in training have you watched somebody go and grab the IFAC and then work on the patient before they open up their aid bag?
Right.
I can barely count how many times I've seen it, right? And then I was talking to Sean, and then I was admittedly like, hey, you know what? I fucked up too, because I was preaching that, and then the March belt came out, and I was like, oh, perfect. We fixed the problem. We've moved on. But what's a March belt? It's a giant fucking IFAC.
Mm.
Right? So we did it again.
Right.
We've redone it to ourselves. So I'm coming out saying I know there's a problem. I think I have the beginning of the solution, but I don't have the answer. So I think this should be a good point for all of us to kind of say, what is the problem specifically, and how do we start to address the individual pieces of it?
Well, I know we were talking the other day about, you were talking about taking chest needles and MPAs out of the IFACs, and at first I'm like, oh, horrors, no. And then I started thinking about it, and we were talking about it, and like, well, yeah, that actually makes perfect sense, where you're going with that. And I think that's the, pardon the pun, or the term, but I think that's the big mind fuck that people are going to have to get around is, I might need all this stuff. So it goes to that possibility versus probability thing, but we're not saying that eliminate everything, because the possibility still is there. So just reallocate your resources and maybe carry less shit, because like we were saying, the chances of having to do a chest decompression are slim, and then actually doing it correctly appear to be even slimmer with the limited data that's out there. So
are you saying, JJ, because are you saying remove them from the IFACs, keep them in an aid bag? Yeah. Are you saying? Okay.
Yeah. So
which a lot of dudes are doing, because in an IFAC, attention develops.
Yeah.
And that's the thing, is so having it back in your big boy toys or whatever is all day. The fact that you may need it right now had to be, there's a large gap then, if you need it now in their IFAC, between their flash to bang time from injury to you treating them.
Yep.
It's a progressive injury. You're not like, boom, I'm hit, I got attention. Right. It develops in the case that you have one. But I think that's a wise move. I know a lot of guys that have moved those off of there and moved them either to, a couple maybe on the march if they needed, and they're working a mass cow and they just don't want to take their bag off, or put it in their bag. So, but I think there's a lot of movement for people putting needles in their bags for that, for sure.
Yeah. So that was my first thing. And then the NPA, the fact with that is, like, to be honest, like, what's wrong with the good old fashioned left lateral?
Dude, positional airway, man. And
right?
to keep in mind, what size MPA do normally people have in their IFACs?
Nobody knows.
Usually,
nobody knows,
right? So,
right?
So what did you say, Justin?
28 French seems to be the most common one.
So you get, and you get some has 26, a lot of them have 28s. And it was from one very, very quick in-house study of about 35, 40 people where they're like, this is the average. But what's that MPA going to do if it's too small, man? Like I can look at JJ right now and tell him he's not a 28, man.
Yeah.
No. You're 30, 32, something like that. So, why are you carrying a one size fits all
I'm like a
thing when it's not a one size fits all?
Now that COVID happened, I'm like a 34 because they COVID the fuck out of my nose. But
dude, that is the worst test ever, man. That literally is a Camelback straw cleaner in your brain.
Yep.
Twerking.
Yeah.
They twerk it. They can twerk it like an ass. It just twerks in your.
I don't know much about WAP, but I know about WAN because that was a wet ass fucking nose, bro.
Yeah.
Yeah.
I've had 4 of them at this point. God damn.
You're an expert, bro. Yeah.
But if there is one thing that JJ does know, and that is twerking.
Yeah. I mean, I can twerk. That's. Yeah.
I mean,
for sure.
no one's going to even argue that, dude.
No questions. Yeah. But yeah, so the bottom line is like, I think that's another piece that we didn't think about, right? We just kind of added in there again, because we were so excited, and it ties to me for my opinion, back to this whole problem with March, right? So we were so obsessed with this algorithm that it was like, well, A and R are in there. So we have to put something that addresses that problem, even though it doesn't actually fix it.
The other side is, I mean, obviously you guys know this a lot, but there is a big movement. I know even from the C-Tech side that we've had multiple meetings and stuff on of just removing chest seals completely, and now a lot of that data actually came from TC3 with Butler, to where there's not been one instance that they can pull up on any kind of MedPud at all. There's never been one study that's actually shown, any research that's actually shown anybody in the history of doing, calculating and taking data has ever died solely from the need of a chest seal.
I think that's fair.
That being their only injury, right? Usually you've got multiple things, right? You have a compounding issue, but that being the only issue, that's it. And I know even within DoD there's movements of, should we really recommend chest seals in there? It's one of those legacy things that I think is going to be hard to move, even if the data completely supports it. But when you look at it, what else is gonna seal that chest up? Whether you think it needs to be covered or not, right? But there's never been anybody that said, hey, their sole cause of death was an open pneumo.
And what has COVID taught us? That cloth masks are really successful at stopping all kinds of airway. So I mean, we could just put a cloth mask over top of it.
But what's interesting is so if you go by the book, right, on something like with a tension pneumo or an open pneumo, right, for air to find this as the path of least resistance to want to come out. Yeah. By definition, right, they say that hole, that entry to your chest has to be 2/3 the diameter of that patient's trachea, right? Anybody's ever intubated is like, this thing's pretty fucking big, man. I mean, besides just being able to feel it on yourself, it's a large wound, which is much more common in military, right, than potentially what we see on the civilian, just from the weapon systems and things like that, especially when we start dealing with potential explosions and fragments from that. But when you look at it, I can kind of feel strongly both ways. No, I could see the different points but in the end, what's going to cause that to close anyways? Is there potentially blood there? If it's penetrating in nature, which just caused it, obviously, you have a property of blood called coagulation that, when people are like, oh dude, we need a vent in this thing. Awesome. Start running it on some, LTT or some different role models like that are bleeding. You're going to see, like, whether you have a ventilation thing or not, man, like that shit gets closed up fairly damn quick. because blood goes right to where that is, and it oddly enough coagulates. But even with a muscle flop, if you think about your pecs and things like that, we've had lots of cases where we've seen where that muscle is just turned over, man, and now all of a sudden it's blocking the hole, dude. You know, so there's so many variables to that.
Yeah, and that's kind of the way I look at it. The body's pretty good at closing itself. So if you just bandage it, stop the bleeding, that's really the main problem anyway.
And really, just change. You're just changing pressures, man. You know, that's it. You know, I think it was Dan Strayland, man, long decades ago. You know, basically, it's like, hey, listen, man, in medicine, like the only things that you do really that are going to save people's lives is you maximize FiO2 to 1. Try to change pressures, shift fluids. Yeah, that's it. Yep. And this is just a changing pressure thing, man. If I put a hand, right, put a gloved hand over the hole, dude, if you put their sock and just stuffed it in that hole a little bit, you just change the pressure. That thing is no longer 2/3 the diameter. Yeah. You just change pressures, man, just by doing that. And, you know, if anybody questions that, you know, we did an informal study with Dave Calloway where we put an improvised pair of socks in his mouth as an improvised ball gag, and he had a hard time breathing.
Okay, good. Sure. Thanks, Dave. I appreciate you being.
And he's a big evidence-based guy, so he should appreciate that. Bless his heart.
Yeah. So, but bottom line is, I think that's kind of brings back to like my whole point here, Brad, is I'm trying to figure out like what's in there for the old-fashioned things I hate, and that's tradition for tradition's sake, right?
Right.
Tradition says it's there, so it's got to be there. And I know we could go on the other side and be like, well, you know, it depends on every single mission, and every single mission can have a different IFAC. Sure. But there is some staples, I think, that we got to figure out, like, what is a good staple? So the first thing I looked at was the two things we already talked about, getting those out. The other thing I've started to do, and it's hit or miss. I don't see a lot of guys doing this still, but early days, everybody put tourniquets in the IFACs.
Right. Yeah, I still see that a lot. Civilian EMS, I'm seeing that a ton.
Like, take your tourniquet out of the motherfucking IFAC, right? If the whole point of this tourniquet is that we're tourniqueting and not pressure dressing because it has to happen fast, because we're under pressure, under fire, or some other situation, then it should be easy access outside of everything else, multiple locations on the body. Right? And ideally, the dude's already done it to himself before I get to him. You know, if I train.
Yeah, and in the end, I think a good idea too, man, is if you're an operator, if you want to keep a tourniquet in the IFAC, that got it.
If you want to,
just make sure you have one or two outside your IFAC bag. Sure. Yeah. You know what I'm saying? That's it. Because in the end, you put that tourniquet on, you're having issues, whatever. Then the medic still has one. If he opens that IFAC to add a second tourniquet on, if that first one's not doing it, or reposition. But if you got one in your IFAC and it fits really nice in there, and you like having it enclosed in there, just make sure you have one or two on the outside, man. You know what I'm saying? Is if you're like, you know, and that's one of those things too. You know, you go to like Noel, right? Sans from SEAL Team. He's the one who came up with that IFAC that we're behind. I love it. But if you look at the reason behind that, man, it's kind of interesting. People are like, oh, dude, it fits behind your plate, so it doesn't take up room on your fight. That was not the reason he created it, man. He had one of his buddies get blown the fuck up, man. And his IFAC got blown up. Like the shit that he had on his outside, on his belt and this, that, like, shit got blown up. Like they couldn't find anything. So it rendered it useless to where like, hey, listen, the one thing that was still on him was his plates. So what if we put something that fits in there, we make it waterproof, whatever. So that's pretty ingenious plan on that, because in the end, you know, I would even say, hey, keep an IFAC on the outside, because how hard is it to get a tourniquet that you're reaching into your whatever? But that's the medic's property right there, bro.
Yeah, like, exactly.
That's part of the medical loadout for the medic, man. So keep your other shit out there. And if you get blown up, you're like that, and you're that fucked up, you probably aren't even realizing that you can do any treatment to yourself because you are a second hind tip, man. At least you have something in order for that medic that's protected, and he can come in and rock the mic, man.
Absolutely. And that's kind of what I'm trying to get at is the IFAC, the individual part has been confused, right? So the individual is supposed to mean it's for that individual. It doesn't really mean that individual should be using it.
Right. Yep.
And that's what's happened is everybody's packing it as if it's like, oh, well, I need to be able to use these things on me. Like, no, it's just like when I've had to, for my entire career, carry everybody else's bullshit, right? I'm like, oh, thanks, radio guys, for an extra battery ×5. Hey, thanks, weapons dudes, for your extra fucking bullets. Well, finally, we figured out, like, hey, it's the medic's turn. Here's a bunch of shit that I don't have to carry. You guys get to carry.
Right.
The only difference is people are actually happy when I get to use my shit. But yeah, so that's kind of the thought process. So that means I think tourniquets should be outside on your body. I think I'm okay with Sean's concept of, hey, maybe keep a tourniquet in there. That concept of it getting blown up is the only reason I'm okay with trying to still keep a March belt but change it. Right? So I still need some extras on that off chance that, like, dude's shit got blown up. But I think that the big piece of that March belt is really actually those, I need it right now, and it's not going to be in my aid bag. And that's things like a pelvic binder, junctional tourniquet, those kind of things. So that's where that, like, I got to figure out how to make it fit, but that's where, like, the AAJT and a Sweet Crow pelvic binder is going to have to fit in my March belt. Does that make sense?
It does. Mm-hmm. Sounds like a packaging nightmare, but
right. Like I'm afraid of that problem set, but it's going to have to get done. And then the other big piece of that, so kind of go down the algorithm, right? So that takes care of the M's. Like I think that for the most part, we talked about put the tourniquets outside.
Sure.
It's been pretty standard tradition to have an ace wrap of some sort in there, right? Or do we all agree it needs to stay, or what's the take on that?
I took them out of the ones when I was repackaging stuff tonight. I took them out. I got maybe 2 or 3, I think, in my aid bag because they're small and they just fit right in that bag. But they're not in my IFAC or in my March belt anymore. All it is pressure dressings, some packing gauze, and I think that's about it. And a little bit more packing gauze. And I think a couple of them I threw in some, just people forget about it. I threw in a couple of those silver foil space blankets. And because they suck flat.
Yeah, I think that's a solid. So what's your take on, like, pressure dressings? Are you doing do you like the Olaces? I mean, I get it, but
so I'm kind of in an interesting space with pressure dressings because I'm kind of a whore for that stuff, because when I was doing stuff with TMS, I had a shit ton of Eliases, and now I have a bunch of shit from NAR, and so I'm kind of, Israelis and everything else, so I'm kind of hodgepodge. But the Eliases, it was actually Galdez that actually told me. I ripped off the eye cups and pulled all the friggin' gauze out of the middle of them, rolled them, and then started vacuum sealing them, which, you jammed me up the other day.
Which brings you to the point of that's how they market, right? Yet that's what we take away.
Yeah.
Right. But so in the end, I don't really give a shit as long as I can get pressure, man.
So, and that's what I brought it up on purpose, Sean, because the point is good pressure, right? So I am tired of all the anti-SWAT tee and all the that super sweet soft tee that you showed me the other day. Because I'm just trying to get pressure, right?
Right.
But what gets pressure better than some type of rubber material that bites upon itself, that I can stretch to a pretty good degree, that doesn't tear and gets tight as fuck?
The only problem that I've seen with, like, the SWAT tee, I don't know if you've seen it or not, but it seems like when you put it on, you get it super tight. Right, you can't do it yourself, obviously, right? It's not a one-handed application. You got to put it on somebody else. You get it really tight, and that's great. But then as soon as there's flexion, it seems like you get reperfusion again. That's the problem that I've seen. I don't know.
Right, I got you. So are you talking, though, for a tourniquet? So here's what I want to.
I don't care about reperfusion, right?
I am not trying to make this a tourniquet.
You're trying to use it. So you want to use it as a pressure dressing, which is,
yes.
Yeah, which I've advocated for as well, is
Right.
using it just as a pressure dressing.
Right. So, and my take is, honestly, I think that's going to be the best option for an IFAC because it's small. I can vacuum seal it like down to fucking almost nothing.
Right.
And it's so I can have choices of lengths too. Right. So that's the other thing I was chatting with, I think both you and Sean about not too long ago, where I was like, hey, you know what we've never done? Guessed it, like what size, how long should a freaking ace wrap be when I'm using it for a pressure dressing? We've just been like, oh, it's
like
an ace
how
wrap.
much of it do you actually need?
Yeah, because the ace wrap is designed not to be a pressure dressing, right? The ace wrap is made to wrap my ankle.
Right.
Or my knee.
Just compression, man. Yeah.
Right. So do I need it to be like 18 feet long?
You know, the only thing I would say on that one, man, is we did some interesting stuff, and it was with Dr. Kane back in the day. He's like a medical director, I think for Alert or something now, man. I'm not sure. But when he was still in the military on the TC3 committee, man, he's just an incredible thinker, man. He was a Ranger who never was a addict or anything, and was a Ranger, just regular gun guy. And then became a doctor, right? Which was the big jump. But in it, I love talking to him because he was super smart and he thought about things very divergently. But one thing that we were looking at, and we did some studies, and he may have done some stuff at ISR when he was there too. I can't remember. But what's interesting is if you take that first wrap, man, and we just wrap that extremity, right? Now, I will be honest with you. One of the reasons I actually looked into this wasn't out of like, hey, let me just like totally reframe the craft that we do on every aspect. Is because we're doing so much improvised shit. And if you're using something improvised, you're already behind the 8 ball. So you really need to see how can I make the efficacy of this improvised shit work a lot better for how it wasn't designed for, right? A t-shirt into a pressure dressing that has a little bit of elasticity. What can I do with it? But anyways, the point being is if you take that first wrap and you get that good anchor seat on it, and that next wrap goes one width, so whether you're using a 4 or 6 inch, one width below, crank that down. The next wrap goes one width above, crank that down.
Right.
The pressure that you just changed in that extremity with the injury, you just holy shit. Because think about doing something like that on something that, let's say you had to pack some combat gauze or whatever in, right? Is if you took a nail, a pass load, to one of your pressurized pipes in your house, man, and then you pulled it out, like it's like like crazy because of the pressure gradient, right? It's the inward and outward pressure that causes that.
And now you've stopped both of those.
Exactly, right? So if you go above that where the blood's coming down, you've slowed that shit down. So you change the entire pressure gradient over that injury, over that hole, right? But the problem is, it's just like your heart. If you don't have it on the other side of it, you can cause it to back right back up, man, just like a fucked up valve. And so by doing that, you change the entire pressure over here. So the amount of bleeding that even like your hemostatic, or if you just hastily packed it with gauze, man, has to do, you just took so much of the workload off of that. It's unbelievable, man. And try it on LTT, man. Like try it on a bleeding role model, and you're just going to be absolutely amazed.
Yeah, absolutely. And so that's kind of my concept, right? And that's why I'm saying, like, let's truly look at this. And I'm not, again, advocating for any of these items specifically because I don't make any money off of it. Anybody want to sponsor me, then we can talk about it. No, I'm joking because I don't do that shit. But my point is, I think that we kind of look at like sizing. And a lot of this is done, one, because I've been in those situations like Sean's talking about where we got to improvise a bunch. But two, because I'm trying to purposely cut size and strategically think about what we put in there so that we can fit some things that we've completely ignored.
Sure.
Right? So we have taken the H out of IFAC completely the entire time I've seen an IFAC, which we've accepted. We've pretty much taken the C out of it. So now it's really just a MAR.
Right.
Right? And is that really where we need to be? And then if we look at like what's really important now and the fun for like little phrases we like to say over and over again, like things like resuscitate before innovate. Well, if that's really the case, right? Cool. Where the fuck is the IV starter kit and the autologous blood kit?
Right.
These IFACs, if we're not doing, if that's what's important.
Well, is that going to, well, for you guys.
Yeah. I mean, it's, again, that's
right. Autologous is definitely key for you guys in an IFAC. But for us in the civilian SWAT community, what
about an IV starter kit, though?
Right, exactly. So I have my IV start stuff is all in my aid bag. It's all vacuum sealed in my aid bag and everything else. But it would be really great if every officer had, every one of the operators on the team had a 16 and an 18 or a 14 and a 16 with a lock, and then, because, you can shrink it, you can vacuum seal it and shrink it down tiny.
Yep, and you could put...
Agree. Absolutely, totally agree.
Right, and now all you have to do there is come and flush it every once in a while and keep going, or it's ready to drop a line in, or it's ready to freaking put some blood in. And the reason I'm doing all this is I'm trying to make space, right, in each and every one of these systems, right? So now you've got space for that. So now I
don't know if you can see it, JJ, but here is IV tubing. The trick with this is you got to be careful because you don't want to squish the tubing down, so you got to be careful.
So the biggest thing
I got some 16s, some 14s, a couple 18s in there. That's just there's no blood tubing or anything, and then I got the IV start kits that are shrunk down too.
Yeah, boom, done, right?
Restricting band and my couple tegaderms and all that shit in there.
Yeah. So for anybody listening, as far as like how to not smash those lines, honestly, it's don't be a cheap ass. You've got to spend a little bit extra money on your vacuum sealer and get the commercial grade, and then you can control the amount of suction, so you don't go smashing your IV lines if that's what you're going to do. If you're not going to do lines, then you don't have to spend money.
The downside too, and I think you talked to David about this, JJ, too, is some people have MPAs in there, and even with commercials, the way that stickiness of it is you will collapse that to where it won't reopen on certain brands, right? And so, even if you're doing something with like even cutting a bougie up or whatever, that's just the length of your MPA and then packaging that in, that'll keep it open for when you do that. Although I'm just not a fan of MPAs, man. Like, I don't think we need them. Like, we use them for the reasons we talked about, and the fact that positional airways, what you want to do anyways. And, at least in the case of JJ2, if anybody gets exposed to any kind of blast, you want them on their side, man, because they're going to probably throw up, man.
Yeah. Yep. Fact.
You're probably throwing up from watching this video too, but that's besides the fact.
Yeah, that's true.
Hey, real quick, Brad, is you mentioned that before, is just out of curiosity, because I probably wouldn't do it the same way you're doing it, is you're taking your ACEs and stuff and putting them into your aid bag. Why were you putting them in your aid?
Yeah, good question.
You asking me?
Mm-hmm. Oh, you said you're moving some of those and put them in your aid versus like a march belt or something.
Honestly, space, because I have in my aid bag, my march. I don't have my belt here; it's over there. I'll grab it in a minute. It's just for it. Honestly, it's for space because I have, I have pressure dressings, I have wound packing gauze, and I have stuff like so. This isn't a SWAT tee, but it's that I don't know. It's the NAR version of it. I don't know if you can't even see it, but it's that white plastic, white rubber bandage that they have. And it's with a couple of, all I did is put some wound packing gauze in there and then so this is kind of the way, this is in my aid bag, but that's kind of the way I'm setting everything up now. So I have the ability to apply a lot of pressure, both with something like this or with a pressure dressing, an Elias or an Izzy or whatever that's flat folded. That's flat folded and vacuum sealed into a form factor like that, as opposed to the big giant rolled thing. Yep. So I just, do I want to unroll and then vacuum seal flat my ACEs, or do I want to just leave two of them in my aid bag? How often am I going to use them if I have? And again, like I said, it's different for me because I have a shit ton of this. I have a ton. I have like hundreds of pressure dressings.
Yeah.
Between Israelis and Eliases, I have bags and bags of them. So I'm not going to run out.
My address?
What's that? You
you want my address? You can send me a few of them.
We go through them quick in class, but I will send you some. Yes.
Yeah.
Despite I tell students, don't use the little clip. Just tuck it under, because inevitably they use the clip, and the only way to get it back off is to friggin' cut it. So we just go through
them. Yeah, I think that's fair. So,
but like, that's an Elias. And for
you, to be honest, I will say there might be some reasons to keep standard ace wraps in your aid bag or somewhere, simply because one of your SWAT dudes is bound to roll his ankle.
And that's the thing, right? Ortho.
Yeah.
I mean, where, a SWAT medic practices sick call, preventative medicine, and or sports medicine. That's 90% of what I do.
Yeah. So it's not uncommon to do it, but I kind of feel the same way as Sean. Is like that should be mostly probably March belt. But then again, I'm trying to push a lot of things in the March belt. Like I would like to see at least one pelvic binder in every actual medic's pelvic March belt.
Sure.
Even if it's that stopgap to doing it, because I kind of feel like if it's in my aid bag, once that opens up, man, like that's a different level patient, right?
Yeah, shit got real, like really real at that point.
And that patient's like getting prepped for evac.
Yeah.
And so on that, whatever's in that bag is for your big boy toys, right? That's why you're a medic. Where those other things, man, are to either augment what's already existing in their IFAC in that March, or to augment it, or to replace it if their IFAC got blown up or displaced or whatever. And then it has a little bit of that stopgap shit that's kind of that phased shit that gets me into my aid bag without having to take that aid bag off, really.
Yeah, exactly.
A lot of people are like, they talk about like, oh, but we see these like JJ and all these guys, man, with like tourniquets, rubber bands to the outsides of their aid bag and stuff like that. And you got to realize like that's not JJ's thing, man. That's if he's running 4 or 5 patients and his guys are helping him, man, that they could just grab the extra tourniquets. That shit on the outside of his aid bag there is like their March belt that they don't have, right? In place of it. So they're able to like just grab and do the immediate shit off, just grabbing tourniquets off those rubber bands off the back of that aid bag. So that's not JJ shit. Like this is my shit.
Yeah.
This is your shit when I'm working on somebody, and because that bag's on my back, man.
Let's be real. JJ's a land pirate. There's no fucking way he's putting something he cares about in an easy grab location.
Yeah.
Because guess what I do? I take everybody else's easy grab shit. Thank you. Have a nice day. Like, I don't know, this hat. I found it one.
That was aimed more at me.
Yeah. But yeah, so I think that's kind of
when a pirate gets pirated.
Yep.
The pirate gets pillaged.
Sometimes you got to call parlay. It happens. But yeah, so that's kind of where I'm getting at. So I think to kind of wrap it up for people listening, like here's kind of our general take. And I think we all mostly agree. So when it comes to IFAC, one, you've got to personalize it to the mission a little bit as best you can, right? 2, when we cover March, like most of your tourniquet piece of the M should be on the outside of the IFAC throughout the body. But you can put an IFAC tourniquet in there if you want. Then you need some kind of pressure dressing. I think most of us prefer something we can squeeze flat, like the SWAT tee, with a little bit of gauze. I don't really care if you spend the money on fancy combat gauze or not. There's not a lot of data that shows whether that matters. I care that you spend all the money you would spend on combat gauze, spend in time and money on training, on being decent at identifying bleeders and packing it personally. But, do your thing. Then when it comes to the A and R's, chest seals, maybe not. Not a lot of data, right? Definitely don't need a needle D in everybody's kit. There's very minimal times so far that we've seen both civilian and combat that people have been needing needles, and everybody across the board has been fucking needles up.
Yep.
So how about you train yourself a little bit? And then after that, you get to freaking the NPA. We all agree, don't do that. Just go left lateral recumbent. And then circulation, if you're in soft or in hopefully soon in conventional forces, put in some freaking autologous kits. If you're in civilian side of the house, probably put an IV starter kit. Does that make sense so far?
IV start and then
yeah.
Not TXA in your kit, but I mean, I would love for us to start. I would love to see everybody carrying TXA on the ceiling.
I was going to say that's what I was going to get at next is should we, I think it'd be nice, especially because TXA doesn't always come in those stupid glass vials now. If you could squeeze the TXA in there,
you could,
right? Because you could do a 10cc syringe, and even if you vacuum sealed it, I haven't tested this out yet, but if you had a pre-filled 10cc syringe and then vacuum sealed it, it might not get pushed up all that easily because it would be a little bit stiffer. Just an idea. And then after that, like you could put the TXA in there with it, and I think you could be able to do slow push right away.
Right.
And then for the H that we've ignored for eternity, you guys said we could probably fit a pretty decent small, emergency blanket, right?
Yeah, space blanket.
Space blanket.
Yeah.
Yeah.
So now you would actually, for the first time since the beginning of IFACs,
have an IFAC that works.
Yeah, and it covers the actual March algorithm.
Right.
Right. So from there, now you bought space because it's actually smaller than it used to be, and it does more. Amazing. Kind of like just this cool thing I've been bragging about where I took my surgical kit that somebody, I don't know, those people might have made gigantic for no reason, but just saying. But yeah, so I think that covers it. So then the big question is what else needs to be in general in an IFAC, right? I don't think you have to fit the 22 feet of webbing in it, but I do think that if you're somebody who wants to be picked up and moved out of a dangerous zone, you should always have 22 feet of webbing on you.
So we've talked 22 feet of webbing. Like there are units out there that's a requirement, right? That they've got 22 feet of webbing on it because I can combine my 22 feet, JJ's 2 feet, and Justin's, and you tie that very fast with EDK 6-inch tails. You have an HMS carabiner. Dude, you got an evac now to an evac line to be able to do an emergency egress where you don't have to pass the knots, man. They slip through. Right. And it's very, very controlled. So freaking controlled. We do it off 6, 7, 8-story buildings, and it's like this is so freaking easy. So controlled. You do have to watch your edge on that, like you do. You don't have to have as much concern with Edge Pro doing an emergency evac with a 7.5 because you've got bulk that it has to wear through if you broke a window out or there's sharp metal. You do have to have something, even if it's just cut a piece of carpet or whatever over the top of that you need probably around that webbing, man. But what a huge capability that is, along with having drag straps, along with having something I can throw somebody out a window with. So with that, having that 22 feet of webbing in somewhat of a commonplace, whether, if you guys are wearing cries and it's down on your calf or it's in your side pocket, whatever, having that available for the medic now gives them an E, which it would be, on March, the E would be everything else in extraction. So now you have that capability to where you're able to rock that mic to where not only do you have the medical things, but you also have a movement piece in it, man, which I think is critical, whether you're using it for a drag or now I'm combining my webbing with JJ and Justin's, and now we put Brad in his own hasty harness. I can connect my webbing right onto that, and I'm lowering you 6 stories, man. You can do the same thing with dog leashes if you're working with canine integrated teams or whatever. But you just added a whole level of capability from emergency egress all the way to moving your ass. Because if those individual first aid kits, man, are for the individual, right? Then I really would like something that would be webbing or a movement capability that's also individual, that we're not having to carry something extra, and bringing that on. There's I guess we talked about now because it's there, but a guy, Dan, who ran into an issue where he didn't have that, took some of the soft litters, man, and this is the thick one, the smaller ones with NAR and stuff like that. Those aren't your primary. You're not like, hey, man, this is our main evac thing, man. A soft litter is never going to be your main evac thing, man, especially if you're going over rough terrain. But if you have it on that person, this is a thick one, man. But when you vacuum seal the regular ones that don't have the buckles on, which you don't need, dude, that thing gets in so small. You can almost fit that into any IFAC as it is without removing shit. And now you've got at least a litter capability that I can move them a certain distance before I can get to a bridges litter or a talon or something like that, which is a huge capability. So between webbing and potentially a vacuum sealed soft litter, like you just exponentially increase your capability for moving that casualty, man. Like all of a sudden, like it gets to the point where you've got to move.
Yep. So
and now I don't want to drag him. Hey, you guys take his legs, I'll take his arms, let's do the shit. Like that's a waste of manpower and energy.
Not only that, but like it's pretty bad form because I'm telling you that patient's going to be in a lot of pain, and it's really hard to grab a lot of that stuff. And that's if he's intact. I don't know if anybody's ever grabbed a patient that just got half burnt from a mortar, but I can tell you skin comes off really easy, kind of gross. And it doesn't taste nearly as good as rotisserie chicken. Tried it, so
I just threw up in my mouth.
Yeah.
Last thing too, just because this is one example of, I mean, that march belt's individual, man. It's to that medic on how they roll, what the mission set is and stuff like that. But just as a little bit of an example, we'll throw out a pic of a dude here, Kit. This is just one example, and he changes his own. But if you look at like March type of things, man, like that's just a little bit of an example of what's on there. And included in there over here, man, is actually the freaking blood carrier, man. That has to be temperature controlled.
Yeah, that's a whole unit of blood right there.
Right, but even when you're looking at this, you're like, okay, he's got rolled up stuff to do pressure in between cats on each side of this, along with what you're talking about before. What is that med that I may need to give? And in that, they typically, if you get into that, you're changing the game a little bit. But here we're gonna make Lucas freaking famous here real quick, man. Dude, just
little man, what's up?
What's up?
What's up?
So yeah, hey, give knuckles to everybody. Knuckles, there you go. That a boy,
man. Good to see you, little man.
And he is getting.
And so when you look at that, like there's some real specific things. And so on this, like the mill side of it, what we see quite a bit is dudes will have crikes in there. But it's important to say like, hey man, this isn't like, oh dude, you're going to need an airway. I'm going to get you some ketamine and we're going to do this. This is like your face is blown off. There is nothing. You're just throwing a scalpel on this guy's throat and putting it in. So probably a little different than what we're looking at from the civilian side, but because the injury distribution of pressure plates and this and that and IEDs and stuff. But it's customizable, but you need to think it through, man. Like make an informed decision on how you do your medical loadout. Yeah.
And I'll give you a quick shout out to Justin Peck, an amazing medic out there who did have to do a crike in that kind of format. It was so bad, though, that he didn't even have to crike. He just had to put his finger into the dude's throat and go, yeah, it should be about where that sternal notch is. Oh, there it is, and then put the tube in, right? So that's why I still say, like, on your March belt, you need the ET tube somewhere available, personally, because that's one of those, like, times where you are going to have to go over the top. And it's happened to several people. It just happened to be that's one guy that I know of. Yeah. But yeah, so basically, I'm with you. So that's a good picture of what a March belt kind of looks like. What March belt shouldn't look like is that you listen to all of us talk about how much we think it's hilarious that you're carrying an aid bag full of IFACs, and you said, "Cool, now I just made a belt full of IFACs."
Right.
Right. So that's kind of my intent with all this, right? So in that March belt now, what you've done is everybody else has almost everything. So in that March belt now, we can throw a couple needles in, right, just in case it actually needs to happen, and there's some delayed stuff. We can take care of the big hitters because what's not in anybody's IFAC so far that we talked about is something that takes care of like your inguinal junctional issues, right? you could probably take care of most of your upper body junctional issues with the IFAC. But I don't feel confident saying with what we've talked about, you can handle inguinal junctional. Does anybody else disagree with that?
No.
Yeah. So that's why I say, like, and how many people do you know that in their March belt, they've got a pelvic binder of any sort? Like, I can say it's not in mine right now. It's going to be. Like, I'm repacking, right? But it wasn't in mine.
You know, and even if you find yourself to the point where, like, as far as like the binder, I think, you know, obviously shout out to with Crow, man, on that. I love it.
For sure.
As far as getting into like multi-adaptable junctional tourniquets, I you know, obviously prefer one because of my background in rescue, man. Because it's the one that is the abdominal aortic, man.
Yeah.
Because
well,
now it's out of the way for everything I need to do to move somebody, man. I don't have to worry about it popping off and stuff. So I love the abdominal aortic, man. And the way that they just updated, JJ and I were
what I love
the
about
creators.
My absolute favorite part about it, I think, is that I'm like a born again Christian. So I was like sinning and hating on it when it came out, and that's because honestly there were some pieces that need to get fixed. But like an amazing corporation and just group of dudes that know what's what, they listened to some feedback and they fixed it, and I can't find anything to say negative about it.
No, and I'll be honest with you, Carl Shorn, who's one of the co-inventors there with Schwartz, that thing's gone through some evolutions, man. And if you haven't seen the new one, I think NAR's carrying it. It is good. We put it through the ringer, Ryan Galdez and I, with the Rangers, man. And we're like, all right, man, we're going to put this on this mannequin. We're going to do some stupid evacuation type stuff through collapse, through confined and vertical. And that thing didn't freaking budge, man. The pressure never changed. So they updated some of the stuff. They took the windlass thing off, made it a ratchet that's way easier to use for the regular operator, let alone the medic. Fast application, and it held like really good. Where we had issues before with the previous model, they fixed it. And, Carl Shorn's kind of that dude's dude, man, doc, but he's, worked flight in the Army, but he also did a bunch of disaster response with Katrina, with National Guard and all that. He's done some phenomenal stuff, but in the end, the guy just cares about getting the right shit out, which is good, which is great. You don't run into that a whole bunch to where he will be like, you know what, like, we got to change some shit, even if it goes against patents or this and that, like, this has got to change, where other manufacturers won't, like, ooh, can't do that. That would be better, but now I'm gonna have to redo my patent and shit. So, and you're like, seriously? Okay. Awesome. That's interesting. That's great.
Yeah. So I think that's
my point of that is they vacuum seal that. And if that's too big for your march, right, then maybe even just consider what we were talking about before is you had that small little thing that you made your surgical roll of.
Yep.
Stuff that vacuum seal in there, and maybe that's on the outside of your aid bag to at least where I can grab and just do a quick pull out. If it's too big for your march belt, right, and you can't turn that march, it's not applicable, because you get into some march belts, man. Guys have deck cord and other shit on their march belt sometimes,
Yeah, so if you go like top of the aid bag, bottom of the aid bag, something like that, where you can pull it out, that's fine with me too. But bottom line,
keep it on the outside, man, and it just releases out of an outside flat thing that you molly to the outside or whatever, man. I know obviously Crow makes some fucking attachments that are pretty badass. So
yeah, just two trailer park girls. And just go
around the outside, man. That's it. Just go around the outside.
So absolutely cover that. So I'm going to do another quick stray voltage. And while we're talking about AAJTs, can we all agree to get these knees off of fucking dicks and groins and put these knees in stomachs?
Yeah, abdomens. Knees in the abdomen.
So interesting thing about that, right? That was a thing back in 2015 was some of the groups that were using is some people were trained just to do it, right? And I get it, man. Like, if you're trying to get their tourniquet out, you're trying to get their packet, either combat gauze or whatever you're packing with, out. Try to slow that shit down, man. Like, if you're watching them bleed as you're fiddling around with something, like, that's a problem. But big butt, right? Middle-aged one. Yep. The thing is what's interesting is if you just took around, 760 by 39 through your upper leg, what's the possibility of like bone involvement? And so they ended up, like, some groups ran into this where they're like, oh shit, man, I just muscle memory would jam a knee down just above where that injury was and stuff. But if you've got a compromised bone or anything like that, and you take that, like, what is that going to do to the vasculature? What's that going to do to the nerves when you take that nasty ass, shardy ass bone and you just applied, 100 pounds of force or more under stress into that thing? It's a mindful game. You shouldn't do anything as a universal. Always do this, never do this. Like, that should not be a part of your vernacular.
Never say never, always.
Exactly. Right. Like, depending on the injury, like, you can literally go higher into that abdomen. You could go and take a fist and be able to do much less damage than blindly throwing a knee onto something that creates a fulcrum on a bone that's already compromised, man.
Yeah. Absolutely. So yeah, just a quick shout out for that, just because it's come up a couple times. So what else do we need in the belt? And so here's something that Sean and I talked about, and I don't think we really settled on any finites the other day, but where does the mighty ambu bag fit? Right? Like, at what phase of care do I need to be like, is it something I need to be able to grab fast? Because it's not that big. Let's be honest. Like, we act like it's huge, but first of all, it doesn't even need that cool little hockey puck.
No.
Right? It's nice to have. I appreciate they made it fits in there, but you can rubber band it, you can vacuum seal it, you can do all kinds of things to make it so it's not that big. And I think I'll have to pull up the literature, but I swear I was just reading something the other day. Welcome to TBI. That's why I'm in this cool little hotel room anyway. That they were starting to say that we should actually use pediatric-sized ambu bags for combat injury.
Interestingly enough, we've been doing that out here in our system for 2 years now. In Monroe County, out here in New York. Our medical director has advocated for that, and it's actually the regional protocols are we're using pediatric ambu bags. And they actually work great. I mean, you're still running PEEP and everything else, but they actually work really well. There are some people that they don't work tremendous on, and you might have to switch over to an adult, but 9 times out of 10, the pediatric ambu bags work great.
Right. And I think it's going to stay blast lung, right? Is that the main idea?
Yeah. I mean, so you have a tendency, people just take that bag and they squeeze the whole thing and pop, right? So this prevents that from happening. And especially depending on, if the acuity of the call is really high and people are amped up and they're either newer providers or less experienced providers, or nothing against them, but you hand it to a firefighter or something like that, they just, they squeeze it. They think they're doing the right thing, but they're not. Yeah. We're always like, slow down on the rate, but we're never looking at the amount they're actually compressing the bag. So this I think it makes it easier.
Yeah, I like it. So so that's kind of what I was thinking. So like, you could probably fit at least one,
easily, yeah.
Like, you sealed into your March belt, and now you can kind of handle that problem set too, right? Because if you're going to get a guy you're going to have to crike in that shitty scenario where you're not even giving any kind of meds or heads up, he's probably breathing on his own, but there's also a good chance he's not going to do that for a long time, right? So
I think it's if you have the ability to take somebody's airway, man, like, you have to have the ability to fucking breathe, man. That's junior varsity. And I think now that he's retired, man, Brad Morgan's, man, is a stud, right? Who did some awesome work as a CNRA, but he wrote a lot of the guidelines that are used in SOCOM and things like that. But he had a great lecture, and he's like, listen, man, if you're going to carry big boy toys, you better be able to reverse it or manage it.
Yeah.
And that's the simple fucking thing of it, right? He, did a lot with developing like jet fuel protocols and all that for just some voodoo pharmacology. But that was his thing. He's like, hey, man, you're giving blood. What do you need? Yep. It's not just an card. You don't need this. That. Like, that's important. You need something if they have a reaction to the blood, man, and you need to pick that up as soon as it happens. You don't need to let it and say, let's just see what happens. Like, he is very, very big on, like, you have it, be able to reverse it or manage it. And dude, if you take somebody's airway, you got that, you're baller enough to do that, then you better be baller enough to manage that. But I think you're correct, is the other side of it too, is the amount of volume that you need. Right. Rate's always an issue, right? People get amped and they do a lot of breast stacking, but volume is a huge issue. And if the fact is you plan on taking that person's airway you're planning on taking it, whether it's through a crike or ETT or whatever your mode is, man, like you're removing dead space at that point.
Yep.
So you can get effective with a smaller volume once you remove the dead space, right?
Well, you're talking like at least 6 to 10 inches.
You are, man. I mean, that's the thing with the tube, man. You remove dead space. It's 101, yeah. But I mean, the thing is, the air that you may need trying to manage it. But if you're bagging somebody, like you're not just like, hey, let's just bag them.
Yeah.
Like you're probably taking, you're bagging them for a reason. You're gonna fucking take that airway, man. If you're a medic, so once you do that, you're going to be able to remove a lot of that dead space and probably be able to make that smaller BVM more effective.
Right. Exactly. So I think that's kind of my take on that. And then, so that leaves space on that March belt so you can still have a unit of blood if that's, an option for you. I think it should be important at least to you. And now look at that. Look how much space now is in that aid bag.
Right.
Like, because at this point, what haven't we talked about for an aid bag?
And if you look at what Paulie's D's doing, man, like even, he was briefing at the, Marines and MARSOC and stuff like that, is like, they're looking at putting blood into IFACs.
Yeah. Right.
And it's become that big of a,
right. And that's
big of a deal, man.
Right. Because that's what's important. Right. So, so my thing is that leaves a lot of space. So the only thing I can think of, like big thing, is a crush kit, right? I think you could easily now fit a crush kit. And when I say crush kit, I'm talking, all the drugs that you're going to need to handle somebody who's been under crush syndrome. You're looking at like some of the other things that maybe to help him get the fuck out of the crushed area, right? Or at least a bone saw if you're not somebody who's going to be able to surgically handle it. Things like that, right? So that's something I think you can kind of have in your big aid bag because you've got time, right? I've got time. If you're crushed under an item I'm going to have my aid bag with me because I've got to figure out how to get you out. I've got to do all the heads up process of getting your tourniquets on ahead of time and all that shit tightened before I start releasing all the fucking nasties into your body. So,
and just to kind of, I'm going to share a screen here real quick, man. But one thing to think about too with that aid bag is one of the things that we did with a team before they deployed, who's an extremely experienced, aggressive group of people, is changing the way that they looked at their rescue stuff, man. And so we ended up, these are bigger than what I carry, right? But we kind of customized it, and it needed to fit into some part of an aid bag. Everybody's using different aid bags, whether somebody's got an M9 and NAR4 or this, that, a custom one that they had, sewn up by Eagle or whatever. But normally there's a pouch on the outside, whether that's from a camelback or that's an outside pouch or that's a mesh netting that's against your back or whatever. That's what we helped them design a vacuum sealed rescue kit for. And so like when you look at that, that's the big one, man, by the way, right? So that's sized to a specific mesh compartment in an M9 for them. And so if you look at it, like that's the content. So when you see that SAM splint, know that the SAM splint is the modified Edge Pro, man. That's it. That's what that's for. So yeah, you got an extra SAM, or you got a sweet ass Edge Pro that you bend over that parapet or you bend over that windowsill, and it works really well because we're using a smaller rope in there. And if you look at some of the components of that, this is a little bit different version of it. That's 75 feet, man. This can be on the outside, and this is a heavy rescue kit, right? So you're able to go up to a 5-to-1 on this thing, and be able to do 1 and 2 person lowers and things like that. So when you look at that, it hits into something like that. It hits into something like this. This is even completely releasable, toggles and all this other shit that's already pre-rigged for releasable anchor systems and stuff on there. But that's something to consider, man. Right? Is now that we have that, what if I am working, and that module only comes in when you're working with multi-stories, man.
Yeah.
And in the end, it slides in. So I don't even have to be the one doing it. If I've got a rope team that's doing it, they just reach in and grab it, or they use it to augment their kit. So I make sure that my kit's the same as my climbing team.
Yeah, exactly. But yeah, so that's the kind of stuff you can fit in there. And then, so now your aid bag has got space for crush. It's got space for that. I can I think Bosch is the guys that you found is the best for the grinders, right?
Yeah,
So,
yeah. They make
battery
their 35 lithium batteries are, you just can't beat them, man.
right? So I can fit that. So now I can actually theoretically go back to this mythical creature we keep chasing called the combination access rescue aid bag. Right.
It is interesting. And so since I guess we're potentially putting this into a video, I don't know. But I'm trying to find like a JPEG, something that'll show up a little bit better. Let me see what this PDF is. All right, so here we can bomb this out here, man. Is, you know, when we're talking about it, you know, anybody that wants a copy of it, you know, hit up Brad, man, and we'll send it. So this is all the elaboration and stuff like this, but you know, looking at the CASEVAC program and shit like that, people have a hard time. It's like, oh God, you have rescue, evacuation, extraction stuff, but you have medical stuff. Like, where do, you know, how do you connect these arrows and what makes that happen? So we kind of wrote this out per tactical combat casualty care and tactical emergency casualty care. Is, you know, if you're looking at that medical loadout, like what do you need potentially to access, right? So whether that's a vertical that I'm accessing people, and or maybe that's breaching into an MRAP very quickly, whatever that is, usually we have an access problem, right? That assess and stabilize is what we've been talking about, man, between our IFACs and our march belts and aid bags and stuff. Then it gets to the point of now I got to think on this from, you know, obviously this is outside of point of winning. This is getting to the point of winning. This is at the point of winning. This is getting out of where the point of winning occurred. And then into the evacuation, kind of gradually moving further and further away out of a threat. So when you look at that and you just think about it as 4 pillars on there, then start building your medical loadout to check it off based on the context of your mission, man. Like, you may not have an issue with an access problem. It may just be breaching or something to get to where they were if you're trying to come from a different angle where there's less threat. That assess and stabilize is based on your threat level, man. So stabilization in one thing might be just enough that hopefully they don't die when you're getting them out, because you're in such a high threat environment. Like even a collapse, a tornado, a hurricane in Louisiana, man, like you're trying to do an extraction of somebody or assess and stabilize somebody, but you're worried about a secondary collapse, man. So the in-depth thing that you're doing there based on the threat that's not somebody shooting at you would be the same considerations as if you had somebody shooting at you or a potential IED or something around that area. It's like, I'm going to get you packaged, stabilized as quick as possible. Whereas if I wasn't around a huge amount of threat and I wasn't worried about a secondary collapse or people shooting, then that stabilization may go further down that road, man, right? Based on what your organic assets are. Extraction, quick packaging, and then it's that transition into evacuation. So if you just use those 4 pillars, it at least gets you to where you're not taking everything but the kitchen sink, man.
Yeah.
Right.
I think it's solid. Yeah. So I think that covers like the whole point I had, Brad, for IFACs. I'm sure we can keep going down this rabbit hole, and
of course.
But before I start, like, you know, episode 3 of this podcast, right? I think that's kind of a good pause area in this stuff. But because I'd love to start going into like what should an aid bag then now look like, right? Because
I think we should do that on maybe the next episode is just the aid bag, and who's carrying what for, you know, some of the rescue tools. Who's carrying them? How are we distributing? So the medic isn't carrying the grinder and he isn't carrying the vertical stuff, and where is that? And
and maybe he should be carrying the grinder. I don't know.
Right.
Right. But what I do know is if this works and we start fine tuning exactly what we just talked about, we just made a buttload of space in our aid bags.
Absolutely.
And I think too is I know
so much room for activities.
So they
JJ, Brian, and I talked about this a while ago, but it was funny, man. There was an interesting TED Talks, and it was from one of those guys on Mythbusters, right? It was the like blonder hair dude with the beard, not the crazy dude.
Yeah, not the guy that looks
shorter dude. But, you know, he did this incredible thing on how he sets his tools up and shit.
Yes.
And that's his workspace, right? And it's first order of accessibility.
Yep.
And so if you start thinking about what you need now and where that's positioned on you compared to the spectrum of somebody decompensating and what that mission set's looking like or whatever, and those items go further back, and that further back is into your aid bag, which is kind of your big boy toys. So where that comes off, shit's changed, man. Like this person I'm treating, and we're getting the fuck off a scene, like we're getting them off this AO quickly, compared to once I control this guy's bleed, we're kind of good, man. He can actually move on his own a little bit too, whatever, and then he can evac potentially with the rest of us or whatever. But when you think about first order of accessibility, like one, it's a really good presentation that you'll be able to connect the dots into medical or rescue. But it makes very good sense, and everybody's gonna be a little bit different. One guy is this guy Jesse Moffitt from Ontario, California, and they're in the process right now of trying to do what we're talking about. Yeah. And it was, you know, he was at a rope class we're doing out in California, and he's like at lunch, hey, can you guys take a look at, you know, me and the other medics' bags and just tell me what you think? It was your typical tactical medic aid bag, right? It was stuffed, the zippers were really tight, and that was it, right? And then basically, you know, we're like, hey, let's just do this quick. You know, we're all just us girls. No one's going to take hard feelings. We just opened it up, and Ryan just started throwing shit around this parking lot or whatever, blah, 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 blah. And it's not like, hey, you know, take this shit out. This is dumb. It was like, we just started taking everything out. We closed that bag up, and it was like, it had so much room in it, right? And then he just created this improv freaking march belt. And he's like, this is this shit, this there. This shit is already what your operator should have on them. This is, you're backing it up what they don't have or what they, you know, they may run out of or whatever you may need a secondary of, blah, 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 blah. And the guy's like, holy shit, man, like that just makes like really good sense. Right. You know, change what they're carrying in their IFACs if you want. Your cordon can always carry a little bit more shit in their IFACs than your entry, right? Which you want anyways, because if you take a casualty, you know, you're going to be bringing somebody in from your cordon to help package and move and bring that vehicle around and stuff like that. So those dudes could have more shit in their IFAC. So you got kind of the cordon IFAC, you got kind of the entry IFAC. You have what's in your march, you got what's in there, and all of a sudden when you list it all out, you're like, holy shit, do I have a lot of shit here. Like I've got that, because that's you own that medical landscape, man. So you just changed your medical loadout and it makes sense.
Yep. I love it. Yeah. So that's kind of the thing. So another thing, before I go too far on some other tangents, I've been looking at, and it's probably different civilian sector again, but I think I'm going to start in a different pocket or whatever, actually making my guys carry their own pain meds. And part of that is because I want to emphasize to everybody involved in this field that the standard size of drugs that we're carrying and the amounts of them are nowhere near enough, right? So the average guy in my community is probably carrying 2 vials of ketamine. We're looking at 10 cc's in each, and that vial, actually 5 cc's, I think is what they are. That vial can handle one patient, maybe, right? And he's rolling around with 2 of them, with 12 dudes and his indigenous partners. Like, is that enough? Right. So I thought about, like, how do we start divvying it up so like each dude's actually just carrying his own pain meds, so that we go, oh, look how much I fucking actually need.
Sure.
Right.
Well, a gram of ketamine isn't going to be enough for 12 dudes. There's no. Right.
Right. But I would challenge you, real quick, diving into the craft of fucking multimodal pain.
Right. Well, that's what it is. Right. That's what I'm purposely setting that
I would challenge.
Right?
Okay. Yeah. It turns you into a baller, right? It's the cookbook medic to, I understand why I'm giving it, and giving it when at the appropriate times, maybe even off-label use because I understand it so well, into the level of Yoda, which becomes your multimodal, which is I can cut my ketamine by a fifth if I couple that with X, Y, or Z.
Sure.
And I'll tell you, one of those drugs that like really seems to do really good with a lot of different things is things like even Toradol. So now you're not worried about, maybe you're carrying the harder drug, but your dude is rolling with some Toradol or something like that. So where synergistically you can find these drugs that just work so well together to where it's an exponent, right? It's a nonlinear interaction. It's a synergistic interaction to where you're using less of everything, but what you're reaching is psychotically higher than any of the individual drugs that you're given at any one time.
Aren't you worried about Toradol though with hemorrhaging? I mean,
based on the injury, man. I mean, you could say, you could start talking Celebrex and shit because that's approved by the neurosciences for bleeding for brain surgery.
Yeah.
But when I say Toradol, I'm like, dude, somebody's got kidney stones or something like that.
Gotcha. All right, I know it's
painful. They're like, Toradol ain't gonna touch it, man. I need Dilaudid. Give them Toradol. They're like, what the fuck?
Yeah.
Man?
Right.
You know, it is a golden
injuries and things like that. So I just threw that out as a blank space, not necessarily for somebody getting shot.
But that is a solid point. Like, you got to be careful on some of that. But the bottom line is, like, and that'll be, again, that's like episode 18. But honestly, Sean and I have talked pretty in depth lately on what I like to call the Pareto's principle of PFC. Right. And I think that's going to be some coined phrasing in the near future. But bottom line is that we can really exponentially change.
Patent pending.
Yeah. So don't steal it. Fucking land pirates. We're definitely going to change the way that you can use your meds and push it to a degree that I don't think people are ready for, which is nice. And it's really just about simple, again, anatomy and physiology. Like, let me go back to it. If you understand the chemicals that are in the body, you can start pushing these things a lot farther. So I think that's really the big key with a lot of the pain management. And also, I just want to say, like, holy fuck balls, please stop putting pain meds in IM, in trauma. Like, what the fuck are you doing? Even junkies know not to fucking IM their drugs. What the fuck are you doing? Fix yourself.
Right. So you're having a problem with that, huh?
Yeah. Yeah. I mean, you look at it. Look at every protocol.
True.
Right? So I don't even blame the medics, right? So I'm saying this, like, and I'm joking but serious, right? I'm not mad at you medics out there doing it. I'm mad at you trainers out there repeatedly saying, and you commands and you everybody who's putting protocols together saying, hey, here's the IM doses that we suggest you do, and putting that as the first line of defense. If you know of someone who has died from pain, please call me up. Fill me in. I want to read about it. But I know no one who has died from pain.
Well, a certain amount of pain can be healthy anyway.
Right? So we're giving pain meds IM, in my opinion, and I'm guilty of this too, so I'm taking the blame. We've done it to make us feel better.
I'd agree with that statement.
Take the time.
There's a lot of things we could do to make ourselves feel better.
Right? And I'm cool with that. We all know I have no qualms with making myself feel better. Whatever that takes, even if it's borrowing hats. So, like, do whatever you have to. But at the end of the day, like, give guys an IV, get that resuscitation going on, then put the pain meds in, and you can control it because the dude is in fucking shock. He's not properly distributing.
I would tell you too, man, this guy's going to hate me for doing this, man.
Yeah.
But the most voodoo dude that I know for multimodal that would be really beneficial, especially for the civilian side, tactical medics. Like, you want to get schooled, like your mom called him and told him to take you to school. Like, you're going to get taken to school. He's that smart. And he's probably got the best name ever for a doctor. Like, if I had a doctor and he introduced himself as Dr. Dangerfield, I would just like, I'm yours, man. That's hysterical.
Yeah.
But yeah, Dr. Dangerfield is like the head of anesthesiology, pre-hospital pain control, multimodal pain, and everything at George Washington. So anybody in that DC area, man, that is your dude. I'm looking at this thing, and I'll send to you guys. But it's a presentation he gave to us at a CTEC meeting when we were at George Washington a while ago. And like, that dude, this 57 slide thing is nothing but voodoo, man. Like, you're like, it changes your entire way of thinking about how to control pain and doing anesthesia pre-hospital. And that's the beauty, is everything on this thing is meant for pre-hospital pain management. Yeah, he is that guy. Unbelievable, from the psychological effects to whatever. And that's where it gets into voodoo, is if you're given something like a benzo or anything like that, right? You're basically just saying, hey, to your body, this isn't as bad as you think. And on top of that, I'm going to cause a little amnesia so you don't remember the pain that you're feeling at any given time. But you're basically messing with the physiology, right, of that and how it's interpreted. The brain interprets that pain, where, when you can get into moving into, and actually that your benzos kind of are a little bit more of a, I guess more of a psychological, where you get into something that's direct pain, your opioids or something like that. That's kind of changing the way that your body perceives it. When you look at your benzos and things like this, it's almost like, this is not the pain you're looking for. It's like Jedi type of stuff. And when you combine those things, like your dosaging on each one goes hugely down, but your efficacy goes through the roof. And just listening to him talk about how he handles like double mastectomy patients and compared to how they normally are with freaking opioid addictions and the pain associated with cutting in those muscles for mastectomies is psychotic, to where he was able to like not even have them on narcotics after they get left the hospital. And the ones that they were on the hospital were so decreased because he combined it with these other things that cause synergistic reactions. Then they're doing push-ups like after the first week, when it's usually like over a month. Like your jaw just drops at the efficacy. And he wasn't big on getting into, like, they told him, hey, you're the head of anesthesia. This is your project. And he's like, are you shitting me, dude? And then once he got into it and he started seeing the effects, he just became like Yoda.
Boom. Yeah.
Cool.
What ifs?
Yeah.
What else? Right. Yeah, I think we got a lot of content for the next 2, 3.
Yeah, that's what I think. Like, so.
I mean, we still got to do the Seaburn stuff too, so there's another one.
Yep.
All right. Well, why don't we'll wrap this one up here.
All right.
And stay tuned for version 2, where we continue down the rabbit hole of
so much room for activities.
Yeah.
Right.
Hey, should you ever recommend like Adderall? Should Adderall be in an IFAC? Is that a thing?
Sure, why not?
I mean, it's already like in my canteen.